Great, thank you very much. I'm, as it says, a GP in Neath Talbot. I was also the Macmillan Framework for Cancer GP until December this year, and co-chair of the Cancer Commissioning Board for ABMU, which has now finished. So it was us that worked on the chest X-ray to CT pathway that Emrys talked about. How many are from ABMU? I know Savita wanted to know the breakup as well. I had loads and loads of emails about when the pathway didn't work, so I disagree with Emrys on that and other things, and it was quite nice to see a consultant complaining about being asked to follow up a test he didn't request. I thought that's a gem for the day, actually. Anyway, the Rapid Diagnosis Centre in Neath Talbot, it's me, Helen, Dr Martin Bevan, and also Kath has just joined the team, and she's the Macmillan CNS for the RDC. We're here to look at vague symptoms, and we were talking about red flags. I'm sorry I didn't catch Cliff, so we may have replicated some of the slides. But what's the dilemma in early diagnosis? The key to improving outcomes in patients with cancer is catching the diagnosis early so that they can at least have a chance of some sort of curative treatment. And when you look at the common things that we know we have all of the time, there's probably less than 50 symptoms that we see regularly, and it can be due to anything. And any of the vague symptoms or any combination of vague symptoms could be due to a number of different cancers, all having different investigation pathways. And for any one cancer, the risk is low. But as a GP, we know, I think, when, oh, there's something wrong, I don't know quite what it is. We know what the hard to suspect cancers are, the myeloma, the pancreas, the stomach, the lung. Lung, very common, but very difficult to diagnose in this earlier stage. It's the non-specific symptoms. And all of these give extended diagnostic intervals. So by the time the patient is in secondary care, it's often late-stage disease. That gives poorer outcomes and a poor patient experience. Also, some of the first suspicion of cancer is in an emergency setting. The patients are unwell, they may be on the pathway with us, we send them somewhere, it comes back, we send them somewhere else. They get ill, they end up in A&E, and the outcome and the patient experience is far worse for the same stage of cancer when it's first suspected in an emergency setting. And even at late stage of diagnosis, for those that go on to receive treatment, often supportive care, the outcome is much better when that's done in a planned way than when in an emergency setting. Definitely the patient experience is better, but there is evidence growing that survival can also be lengthened. And from the Health Board's point of view, it's more cost effective. You've probably seen this the third time now, I gather, but this is what we're about. People with cancer, people in a room that have cancer, 50% will not have red flags. So if we concentrate on the red flags, we are missing 50% of people. Wales did its first international first cancer conference in 2015, and a group from Denmark came over and first presented their three-legged model. So a team from Wales went over in April 16, and I was one of those teams with Cliff, and we visited Aarhus University. Cliff and I went to a GP practice and to the Diagnostic Centre, and the aim was, will this setup work in Wales? We know it works in Denmark. They were far behind in their cancer outcomes to the rest of Scandinavia. They were very embarrassed by it, and like with everything, a politician's relative developed cancer at a late stage, and then the focus was on, so they worked really hard and they realised red flags, that's not the only thing, so they brought in the vague clinic, and after that then they did see their cancer outcomes improving to be more in line with the rest of Scandinavia. Yes, they've got more money, yes, they've got more radiologists, yes, they've got more scanners, but it's not just about that, it's what you do with them. And so, as one of two pilot sites in Wales, we were granted monies by the Welsh Cancer Network for a 2-year pilot, one in Cwmtaf and one in ABMU, which has been sited at Neath Talbot Hospital. So I'm just going to hand over to Helen, who's the manager. If I can untangle myself, sorry.
As I said, my name is Helen Gray. I am the RDC Coordination Manager at Neath Talbot Hospital. I actually came into post 2 weeks before clinics actually officially started. and my role is extremely varied. I am the booking clerk, I'm the medical records clerk, I'm based in clinic, I also am the secretary, and I'm the keeper of the data as well. So I'm part of a really nice small-knit team. So Heather is our clinical lead, my manager's Kim, Catherine is a brand new CNS, and we realised very early on when the clinic started that we needed her input. Julie is our amazing healthcare support worker. She helps with the ferrying of patients around, chaperoning, but generally just making them feel at ease as well. And on a daily, our clinics are held at the moment on a Tuesday and a Friday morning, and due to timetabling restrictions, we got different radiologists and different consultants based in clinic at the same time. So the clinic structure is, at 8:30 we all meet. We've got a radiologist and a clinician available there. Myself and Catherine will turn up as well, and we decide what test will be best for that patient at that point. Then during the morning, the patient will have the test, they'll have a top-to-toe examination by the consultant, and they'll also go home with the results of that day as well, and knowing what's going to happen next. So the main aims of the pilot were to reduce the time taken to diagnose a patient with something sinister, to improve the patient experience, but also then to have a bit of a knock-on effect with mortality rates and see if we can improve them. So background, a little bit more background. This is actually a picture of our waiting area. So we've got access, our clinics are actually an elderly day unit. Lovely facilities, tea and coffee on tap, TV, books, nice area to walk around if needs be, but we've got space for patients to bring relatives as well. So we started receiving only electronic referrals on the 22nd of May. Our first clinic was then on the 6th of June. And since then, these were just for the 3 GP clusters in Neath, and since then we've been looking to expand. So we've done the 9th of October, we expanded to Bridgend North, and then we went into 3 Swansea clusters, so Cwmtawi, City Health and Penderry. And when we started small, the demand wasn't there, and we've been developing that, so we went into 2 clinics then from the 10th of November. And what we're looking for is we're looking at those really vague symptoms. So weight loss, appetite loss, nausea, fatigue, anything that really doesn't mean much because there's so many things it could mean, but we're based on the clinics based on the GP's distinct gut feeling there is something sinister going on. So we're all based on your opinion. Okay, so coming into clinic, this is a pilot. We've got an inclusion and exclusion criteria. So the inclusion criteria is we need a set of bloods, a chest x-ray, the patient needs to be above 18, they need to fully understand that they're going to be called on short notice, and most of the time it is short notice. The referral comes in on a Thursday, I'm looking to book them on the Friday if they're good to go. And that they understand, and a contact number, because I ring them and I give them all the information over the phone. So set A, bloods, the usual bloods, full blood count, and then a couple of tumour markers, but most of it is the chest x-ray and a top-to-toe full examination. And this is because if you're feeling that there's a site-specific pathway after an examination, you need to send them on that site-specific pathway. So these are anything non-site-specific, and we will send them back. Just to make things a little bit speedier and a little bit easier for you guys, we've actually created a blood form that is recognised in all ABMU pathology, just for you to just tick which ones we want done, and we're all good to go then. So the exclusion criteria. If there's a site-specific symptom or site-specific sign, we will send it back to you and ask for you to be referred onto the site-specific pathway. These are only for vague symptoms that you just don't know where to go. Anyone under the age of 18, and I didn't mention this before, it was on the previous slide. If a patient we think it's a reoccurrence of a previous cancer they've had and they're currently under monitoring, we will ask for them to go back to the monitoring first. If that's all clear, then we'll quite happily see them in clinic. We have set up in the clinic that if a patient's, we've not found anything and the GP is still worried after 3 months, then the patient can more than welcome be referred back in, and we'll see them again and see what we can do. So as the pilot's been progressing, we've got a bit of a plea to the referrers out there. So one of the things is we've actually had quite a few patients not even knowing they've been referred to the clinic. So if they've not been referred and I'm trying to say, oh, I need you in for tomorrow, they're getting the anxiety up because they don't understand why they're being seen so quickly. We also send out gas GPs to give a patient information leaflet, which just backs up quite a bit of the information I give them. So patients come in starved, so no food or drink from midnight the night before. There's certain medications I need them to stop before coming in. What they're expected to happen on the day because they're with us for the morning because they don't understand why they're with us so long, and just silly little things like that. And we only accept electronic referrals. So the process at the moment, the referrals received electronically, it gets vetted either by Heather or by Kath, or Dr. B if he's lucky. And then bloods and chest x-ray, I check them, I liaise with you if I think there's any missing, and then the patient's booked into clinic. So overall, up to date, as of last Friday, we've actually had 51 clinics. We've seen 115 patients. Now, month on month, the ratio between male and female is actually quite even. And our age range has been quite dramatic. So the youngest we've had in clinic is 26, the eldest we've had is 95. Month on month, we've actually been seeing the average age come down slightly. So when we started in June, the average age was about 81. As of last month, it came down to about 67. So overall, we've actually had, out of those 115, we've actually had 103 patients have a CT in clinic. We've actually managed to have 2 barium swallows done on the day of clinic, and ultrasounds and echoes as well. We actually have access to ECGs and things like that. Those patients that didn't have any investigations, we've actually had a couple of occasions where they've recently been CT'd for a completely different problem, and we've actually managed to diagnose them off that CT as well. Okay, so looking at the referrals, we've actually had 152 referrals actually into the department. We've had 126 accepted. The difference between seeing 115 and 126 accepted is we've actually had a couple of people that were unfortunately so ill that they actually ended up in A&E over a weekend, and they've been diagnosed with renal cell carcinoma, ovarian tumour, and most recently a lung cancer as well. So for those reasons, for the 26 that we've actually returned back to you was because there were site-specific symptoms, and 6 were only sent back because they were either I had received them in paper or there was no physical examination and the criteria wasn't met. We actually have rejected a little bit more than that. We've actually rejected another 23, and that's because they were sent to us as an urgent suspected cancer. And before that reason, we've had to reject them and ask them to be resent as urgent, and we quite happily see them in clinic. Bit of politics behind that. So NWIS has said, because we're not an urgent suspected cancer pathway, we can't accept USC referrals. So overall, what I've managed to do on the bottom left is the clusters. So we're showing a general increase of the number of referrals received. I don't know if you can see, but right at the bottom, there's a couple of little orange ones. Didn't come up that well. What we did is very early on, we decided we wanted to allow ACT team in Neath access to this service. So they're secondary consultants based in primary care, where they'll do home visits for those that need IV antibiotics or dehydration, things like that. Just breaking that down a little bit more. I know it's so small, apologies. On the blue on the left and is Neath Talbot clusters and the number of referrals we've seen and the number we've rejected. Me and Catherine at the moment, we're highlighting those the ones that we want to target and try and get to promote those with high rejection or no referrals, get some promotion work and get some referrals in. Bridgend North is then on the right, and then Swansea is the middle one. We're looking to do a lot of work with Swansea. We think there's a lot of potential out there into the clinic. This is coming up with its own issues, like transport, and what I've managed to do is I've managed to arrange with community transports for both Neath and Bridgend at the moment, where they actually bring the patient in clinic for 9 o'clock, ready and waiting. In Neath, I've managed to get this for free. In Bridgend, the patient has to pay the 45p a mile, but we can get that transport sorted then for them to come home. Okay, apologies, this didn't come out as well as I expected. What I did was I've done a stachygraph of how many symptoms patients came in with and what did they come in with. So literally the whole of the bottom line is green, and that means weight loss. So those unexplained weight loss, and this is extremely varied, from a GP referring in with literally a couple of kilos weight loss because it's very, very unusual for that patient, or someone with a 9-stone weight loss in 8 months. It's extremely varied. And what we can see, there was a couple of correlations coming up, and that was the biggest one was appetite loss, and you'd expect the weight loss then with that one. So what we did afterwards was we realised very early on that nothing really fits into nice little boxes. So what we've done is we've split the outcomes into patient outcomes and then clinic outcomes. So patient outcomes, what we've managed to do is we've distinguished into 3. So there's the cancer diagnosis, the non-cancer diagnosis, but related to the symptoms of being referred into clinic. And then there's no diagnosis, which means we didn't really find anything. We couldn't explain the symptoms. But then they also included incidental illness that we found as well that needed actioning. Just to give you a bit of a process thing, the radiology report goes back to the GPs there, and then they actually get it before we actually get it. And we actually aim to then get all clinic letters back to the GP electronically within 24 hours of the clinic. So as I said, patient diagnosis, we're actually showing a couple of bits of trends as the numbers increase. In the very beginning, the very, very first month we had, it was literally 50-50%. So 50% cancer, 50% not cancer. It was a shock. So what we managed to do is, and at that point we realised we needed Catherine's input, we needed that nurse, we needed that onwards management between leaving our clinic and then MDT and then following up by someone else in secondary care. As the clinics progressed, we understood then I know it sounds daft, there's a little orange one just above the red one on most of those bars. And that orange one is those that we still can't rule out cancer. We definitely think there's something going on, but we can't physically do that test in clinic. The biggest example of this is if we think it's hematological and we need a bone biopsy, we're not set up to do that. So we've referred on to secondary care for them to pick that up, and we're monitoring just to make sure it doesn't come back with cancer. The non-cancer, the green above the yellow, which you can't see, those are, we've actually found some really weird and wonderful things, which I'll go into in a bit. But we are actually coming up with some really significant findings as well. No cancer, no diagnosis, so they're the light blue. They're the ones that we didn't really manage to explain their symptoms, or we found the incidental illness. So we are finding there's quite a few. At the moment, the Denmark model is around about 8%. We're currently at 7% for cancers. The dark blue seems to be getting bigger and bigger as we're going along, and that is because we are asking for further investigations on part of radiology input, so MRIs, OGDs, colonoscopies, and we can actually do that in-house. We've actually set up one endoscopy list a month for the RDC, where all our patients get immediate transfer into that. Okay, looking at the cancer diagnoses then, we've actually had 9 confirmed so far. 4 lung, 1 colorectal, 1 lymphoma, 2 pancreatic and 1 MUO. Unfortunately, the lady was so advanced, we couldn't investigate any further to find out what she got, and we needed that palliative care input. Just to give you an idea, the 4 lung cancers, quite a few of those were diagnosed early on, diagnosed in the beginning of the clinic at stage 3. We've actually had 2 stage 1s picked up recently, and that was because of sizable lung nodules that needed that extra monitoring. And both those patients have gone on to have lumpectomies. As I said before, there's a further 10 people that we're actually monitoring as well, so the number could go up. And just to give you an example of our, best case scenario that's actually happened in clinic. Patient number 6 was diagnosed with colorectal cancer. She was seen in clinic on Tuesday, MDT on Thursday. She was actually seen and had surgery on the Monday the following week. So she had definitive cancer treatment for her colorectal, within 7 days. Okay, this is something new that we were trying to explain. What we've managed to do is, the red is the RDC for a patient with respiratory, and then the blue is a normal USC pathway. So stage 1, which is right in the bottom corner, is the referral being received. Stage 2 is the patient being seen in clinic. Stage 3 is the CT being requested. Stage 4 is the CT being having done. 5 is the reporting, and number 6 is either the patient being followed up in a respiratory clinic or our patient being referred on to a respiratory clinic. So as you can see, we're actually cutting out quite a bit of that middle ground because it's all happening on the one-stop shop. So those non-cancer diagnoses that I said about those other distinct things that we found, we've actually had quite a few cases of tuberculosis. And we've had a really nice one recently. Sarcoidosis. The pulmonary embolism we had in clinic was really quite sizable, and because we were based in the elderly day unit and there was a general physician next door, he actually managed to have his treatment started there and then straight away for it. We've had some other weird and wonderful things. Mesenteric panniculitis, the inflammation of the fat around the colon, and polymyalgia rheumatica was not diagnosed, but it made her feel a lot better when she started the treatment. The incidental findings we're having adrenal masses and other weird and wonderful things. So as I said, those are the patient outcomes. Clinic outcomes, we wanted to know what impact we were having on other services in secondary care. Overall, we're not having that much of an impact. The only one we're having an impact is with respiratory, and that is the sizable lung nodules we're finding, the sarcoidosis and the tuberculosis, the quite a few cases that we've had in clinic. The other impact that we are having is we have actually had to have 2 patients admitted to hospital from clinic because they needed urgent actioning there and then. So one lady was unfortunately dehydrated so badly, and the other gentleman needed chest drains for effusions. As I said, one of the main aims was regarding patient satisfaction. So we've actually had 99% positive feedback in clinic. We do 2 questionnaires, one in clinic to engage their behaviour and their GP's behaviour. And the second one then is an overall experience, the before, the middle and after, and then we take whatever they say and we try and work on and see what we can improve. As I said before, there is work that we need to do with our GPs, and both me and Catherine are going to go out to each GP practice individually, and it is, please tell your patient they're being referred. We're actually showing a bit of a 2-way anxiety thing going on at the moment of why are they being seen so rapidly? You know, the anxiety, well, it must be serious if I'm being seen so quickly. The other anxiety is then the relieving of the anxiety when they leave our clinics knowing that they're okay. There isn't what they thought was going on, and that sense of relief as well. I'm sorry that these haven't come out so well, but these are just some of the examples of patient comments. This is not even half of what some of the fantastic comments we've had. But just generally, people are very pleased with what they've got. The team we work with, they're so supportive, and I know it sounds that they enjoy their day out. So what we're looking to do in the future, we're promoting the GPs. We're going to focus on the 7 clusters that we're with at the moment before we think of expanding any further. We have the potential to expand to another further 2 clinics. We're just trying to work out the logistics of that too. We're sending a GP evaluation questionnaire as well out, so we're going to be looking at doing some work with that. And the way of improving the patient pathway is looking at standardising radiology. As I said, patients come in completely starved, no food, no drink from midnight the night before, and they are desperate for a cup of tea. But if I can at least provide water, if we get those standardisations with radiology in, they can drink water, they just can't drink tea until we see them. And as I said, Catherine's new, we're evolving the role of the nurse in our clinic, so we're looking at promoting everything and anything we can possibly do. She's our onward support for the patient as well before they get changed, before secondary care take over. And we'll take it from there. And do you have any questions?
Is this happening anywhere else in the country?
CumTAF. So CumTAF is our sister pilot, so we're doing a comparison study between the two. But over the UK there is various different, there's the ACE project in Manchester.
It's in England in general, but they tend to be a bit more site-specific, rapid access for jaundice, or if you've got this 3 collection, so a little bit more specific and not as open, big, and can be anything. How is it comparing with CumTAF?
CumTAF have just gone area-wide. They actually started about 2 months after us, so their progress is as slow as ours. But we're starting to pick up, and so are they. We're looking to do a bit of a comparison work now at the end of the year.
So you say they're pilots. When are you going to tell us whether they work and when you're going to roll it out to the rest of the country?
It would be lovely, wouldn't it? It's a 2-year pilot. We've had funding for both sites have had funding for 2 years. The choice won't be ours whether to roll out. There is going to be quite in-depth evaluation. We're hoping to do an interim one now, but we've worked with Wealth Cancer Network and 1,000 Lives, and in a way you're doing it on behalf of them. So the decision won't be ours. Hopefully it will be such a success that they can't ignore us.
Sorry, when you say email, is it electronic referral via WCCG?
WCCG, yeah.
And where does it come into
If you're a referring practice, it will be in your drop down, but it's ABMU only and the 7 clusters only. So if you're not within that cluster or not within ABM, you won't see it in your drop down.
Yeah.
So it's a real cynic. I mean, you've seen 115 patients from 52 clinics. That's only 2.2 patients each time. I mean, and listen to the resources you've got. That isn't economically viable.
Yeah, I'd agree. It's very.
And you know, you've strict criteria. You can have a blood test. You've got a full examination and a chest X-ray. And you admit a lady for drainage infusion. How the hell does she get to you?
I would agree that it is a very resource-rich clinic because you've got a consultant physician, you've got a consultant radiologist, you've got the nurse, you've got all the backup staff. And actually it's a very nice clinic to do because there's a maximum of 4 patients per session, which is lovely, you know, and you get your results straight away and fantastic. So there would be major resource implications if this was rolled out, and that's what the pilots are there for, to see if it is financially viable. But I'd say from a clinician point of view, it is really interesting doing it because you can have completely normal, those set of blood tests can be completely normal. And for example, you've seen some a patient there, normal ultrasound abdomen as well, and then you do your CT scan and there's a big pancreatic mass there. You know, and so just from a clinician point of view, normal abdominal ultrasound with ongoing symptoms is not at all reassuring. You know, you need a CT really. But I agree, it is a very generously. The reason why a relatively low number of patients will be seen is because the slots weren't being filled. That's why we're expanding the geographical area that the patients are coming from.
We've had very few clinics that have been completely full because we knew, and it's GP's referral behaviour. From the point of view of the pleural effusions, the advice is that you have to have requested the set A, and they need to be on the system. You don't have to wait for them to come back. So even if, for the purpose of the pilot, it is obvious, we will still see them in clinics. So the GP may have seen that, but know that we were seeing. We're 2 clinics a week, so any referral, the wait from referral to being seen is 3 days or less. So often the GP will have had the results at the same time as we're looking at it. It is very labour intensive, and this is the start-up of the pilot. I think one of the main aims is a culture change. This is a diagnostic centre for GPs. You shouldn't have to have all of this rigmarole. We should be able to request CTs on people we feel appropriate. In Denmark, it was very much radiology-led. They've been doing it for 5 years, so it is a process. The radiologist, as a physician as well, seeing the patients, looking, and only a small proportion went on to see the physician if the initial tests didn't show. So the hope is that it will be rolled out, not in this setup. This is a learning, and this is a development of skills. We don't have enough radiologists, and we definitely don't have clinical radiologists in the form that this is. But this is about a cultural change. This is about doing what's best for the patient in front of you now, and trying to look at ways to take out the diagnostic delay. And if all that happens is that the health board sees that waiting and earning a CT 3 months down the line, and then earning the right to go to clinic, which the CT then has to be repeated because it's so old, we have to change the way we're doing. So it is about saying that we can't stand still. It is labour intensive, but sometimes you need that up front to prove the point, and then you become smarter at it.
And I'd also say that being in the clinic, the attitude of the radiologists has changed from when they started to now. The acceptance of doing a CT scan is much, much higher now than it was before. You know, because a radiologist always says there's always a reason not to do it, isn't it? But now they're agreeing to do it, and it has changed their mindset, isn't it? Which could be quite useful educationally for radiologists.
And I think outside of primary care, people don't understand, well, I think, that the value of a negative scan, of knowing that there isn't anything. They're doing this across the UK and in other countries, and a GP in Scotland says that they're doing a similar thing, and the patients don't come back, either because they've got a definitive diagnosis that's being managed, or because you had a low suspicion of cancer, but when you think it is, you need to know. So yes, everything is okay, you can get on with your life, obviously with the safety net and everything. So it is about this small part in the patient's life, but it's about their outcome, and just trying to cut out the delay so we can get where we want to be and then move on.
Can I also add that we don't waste anything? So if I've got a clinic with only 2 patients in, I release those 2 CT slots back to radiology for urgent suspected cancers to be seen and to be dealt with. Same with our gastroenterology list. If we don't fill a list with our patients, they go back and new SCs are put on too. So there is no wastage.
Yeah, I was just wondering, the referral rates seem quite low considering the size of the area. So how has the service been with that? How have GPs been told about this? What information have they actually given?
It started off in Neath Talbot, and I'm a Neath Talbot GP. So I went to the PT4L and promoted it through as the pilot was ongoing, and once we've opened. We've then been to cluster meetings in the clusters that have been involved up in Maesteg, and then the 3 Swansea ones. I went to some of the Swansea ones, not all of them. It's been difficult to have the time. I'm GP and things as well to get out, so there's been emails, but now that we've got Kath on board with Helen, we'll be hoping to go to many more of the GP practices. We have been emailing, Helen and myself have been to a few practices, we've been contacting practice managers, can we tell you about it? But it's mainly been through the PT4L sessions and to the cluster meetings of the 7 clusters that are involved. So if you don't know, every cluster meeting has been attended, so, and that was last year, that was definitely back in last year, we haven't done any this year, so ask your cluster lead, why didn't they pass the leaflets on?
We have seen a dramatic number of, since November, literally most clinics are now full to the capacity. So demand and capacity at the moment is evening itself out. That's why we're looking to do a little bit more promotion work before we go any further, because there is that potential. You know, Swansea, there's quite a few surgeries in Swansea that haven't referred at all, and we're looking to then re-promote in Neath and get Bridgend on board as well.
Just how often are you sort of looking at lesions of uncertain significance in CT, which then
Infrequently, really infrequently. So we've had about 2 adrenal masses, 2 adrenal lesions. We've got a couple of people being monitored for bony lesions. The number compared to cancers is minimal.
Quite a few pulmonary nodules, then gone on to PET scan, which have been negative, so then it's just, you know, so nothing, I think, huge coming through.
It is a risk, and it is one of the many downsides. I think the upsides sort of take more weight, but it is a risk, and obviously patients and GPs need to be aware of that. But we haven't had a massive issue with it so far.
as we all scan patients.
We don't do any positive oral prep. It is literally the Fentanyl. What do you call it?
I have no idea, you know much more about radiology than me now.
That's why we're trying to standardise the way the radiology is, so we can get them drinking water. So they're only using water as the negative prep, and it's just the Ventolon then, which is from what I understand from the radiologist, it's a very minor dose of radiation. If there's a creatinine problem, then we do non-contrasted.
I appreciate it's probably a little bit early from the audit of your work today, but is there any evidence from the Danish model that it's the expertise or the physicians that are in the clinic or the educational value of going back to primary care that is the best outcome?
It's the access to diagnostics. The majority don't see the physician. That's only probably less than, it's about 20-25% from memory that see the physician, because the radiologists act clinically but also basically doing the scan with the GP symptoms and speaking to the patient. They're able to give a clear yes or no. It is a GP diagnostic centre there. It was a hospital very much like Neath Patol, but used to be inpatients, then was outpatients only, and was sort of struggling to find its way. They now have one per region in Denmark. There's 5 regions of about 1.1 million each, something like that. They are more affluent. The education level, there's less a divide between sort of the most rich and the poor, and the educational level in general. GP workload there, 25 contacts a day with the practice we went to, and that's including phone calls. It was lovely. It was a designer-built health centre. Yeah, they all finished by 4.
Anybody speak Danish?
You don't need to. The level of English is fabulous. I want to work in Denmark. It was very inspirational for lots of reasons, but mainly the culture in the hospital of doing what's best for the patient in front of you now. It is a high dose. It is intrusive. They're there all morning. The elderly care unit is fabulous in hosting them. But they're there because the GP suspects something sinister that could be cancer, and the only way to improve outcomes is to get it at an early stage. And the reason that we are so poor in Europe and in Wales and in the world is because our stage of diagnosis is late, and so we can't offer, irrespective of comorbidities, even the young 53-year-olds, we can't offer curative treatments.
I would say someone does need to examine the patients in the clinic. So, because we haven't got radiologists here are not trained at the moment in clinical examination as well. Particularly, although some of them are very experienced in it. Just I know the patients are meant to have a full exam before they come in. One chap, after I'd listened to his chest, he says, "Oh, that's the first time anyone's ever listened to my chest," which I thought was quite funny.
And people tell Hawkins as well.
Yeah. But sometimes even with a CT scan, you do need to correlate it with physical examination, because there can be, heart failure or interstitial lung disease or lymphadenopathy. There's a differential which you will, correlate with the scans. You do need to examine them. Also, there was a lady who had something showed up on the CT. It looked like a strange mass in the chest wall, but in fact it was a benign skin lesion. But if you hadn't looked at her, there was no way the radiologist would know that was there.
It's a very interesting session. Beforehand, we speak about everyone. I attend some of them, not all of them, with the referral and the results. Then the radiologist, the physicians examine, and then everybody gets back together to correlate. And that then, the physician, it's like it used to be in the old days, you'd actually speak to the radiologist, you say, well, this was a sebaceous cyst, and then the patients are brought in and the physician tells them, so they leave within a few hours and they have everything. They have the plan, the diagnosis, the assessment, sometimes some treatment, dietitians, particularly with Kath now, working out a team of starting the holistic assessment. We have welfare rights, we have, as I say, a dietitian, we're in the care of the elderly. Income TAF, it's slightly different. Now I know I would say that, but they're set within their emergency department, and so there's slots, and their emergency CT is running all day, and so they're slotted in and out of that. It's a different environment, and there is no right or wrong way. But so I think the evaluation will be looking at the things that work for both and the differences. So it is good that it is different.
Okay. Good. Thank you very much. That's great.